Uh, the primary assessment in my day was called the ABCs. You do the ABCs. It's still called the ABCs, but they give it another name where they just call it the primary assessment. This is the second leg of this. You do the scene size up. Then once you make patient contact, now you do the primary assessment or the ABCs. So airway, breathing, circulation, you focus on what is life-threatening. In your ABCs, like we talked about in CPR, you don't go any further until you fix it. So if you have a problem with the airway, you fix that problem right then. The problem with the breathing, you fix the problem. Maybe not definitively fix it, but if they're having trouble breathing, how do you fix that problem? No, they're breathing. They're just having trouble breathing.
You give them oxygen.
You give them oxygen. So you give them oxygen, you fix that problem up to your skill set. Circulation, what do you do if they don't have a pulse? CPR, right. So you fix that problem. But, so you go through here and you look at the patient condition, the resources that you may have, but primarily what you do, first thing, once you do your size up, you get your good general first impression, then you do your primary assessment or your ABCs. They're teaching this now, this CAB, circulation, airway, breathing. If they appear to have no life, no pulse, you immediately start CPR. You don't go through the steps of opening the airway and do that. You walk up, they look dead, you check a pulse, they don't pulse, you start CPR. Why is that? Anybody remember?
Because the little thing you said, it'll get low too fast and you can't breathe that fast or something.
Right, the coronary perfusion pressure. They want you to make sure as soon as possible you get the coronary perfusion pressure back up. So you start CPR. Primarily, we're going to go with the ABCs. You know, you can do your ABCs in just a couple of seconds, so it doesn't take long for you to actually do them. But they want you, the reason they have the CAB is to emphasize the importance of starting compressions right away. So when you look at this, you form your good general first impression, you assess the mental status using the AVPU scale, remember that? And then airway, breathing, circulation, and then last, you do all that and you say, is this a high priority patient? Do I need to transport this patient right away, or do I have some time at the scene? So these are the things that all these things you do within, I would say the whole thing within 30 seconds. All this is done. Probably much sooner. In a conscious patient, you can do your ABCs in about 2 seconds, right? You walk up to the patient, you grab a radial pulse, and you ask them a question, and they speak to you. Your ABCs are done. Now, in an unconscious person, like here, you would have to go, are you all right? Then your ABCs are done here, except you reach out and grab a radial pulse. See the difference between that? So you have all these things that take place very quickly. This may take a little bit more time to determine whether that's a high priority patient with experience or no experience. So once you get experience, this determining the priority of patient will come very quickly to you. If you walk in and you're forming that good general first impression and they're gray-ish, they cyanotic, then you know right away that that's a high priority patient, correct? If you walk in, they're clutching their chest going, I think I'm having a heart attack, high priority patient. If they're if you walk in and they're holding their finger going, that's the worst paper cut I've ever had in my life. Really? No priority patient there, correct? So remember, all EMS calls, 85% of them don't necessitate an ambulance. So the majority of EMS calls are not high priority. They're low priority patients. Then as you go and you look up your general first impression, the environment is very important to you. This gives you a lot of inside information on the patient's well-being. You know, if you go in an elderly patient's house and it's the middle of wintertime and it's cold in there, all right, do they have money for the heat? You know, you look around and you start trying to find food and you don't see any food laying out or any signs that they're eating, that sort of thing. The diabetic patient that we spoke of, are there needles laying around? All these things right here give you some sort of, the environment gives you some sort of clue. Then you get in on the patient's chief complaint. This is what the patient tells you. Then you look at the patient and say, hey, you know, are they warm, pink, and dry? Are they yellow? The cyanotic? Are they bleeding? And again, helps you determine the need for transport and how rapid that you would transport. So look at other altered mental status. We'll go into a whole thing of what causes altered mental status. Do they have a lot of anxiety built up? Are they not warm, pink, and dry? Obvious trauma. Are they in distress? Do they seem like they're in distress? Do they seem angry? Do they seem sick? Most sick people, real sick people, are sort of dormant, you know. They don't like to move around very much, and they're just sort of obtunded. And these are the things that you sort of pick up on. So your senses play a huge role in this. You look, try to get the patient's age. Their gender doesn't really make any difference. Where they are, their position, are they laying in bed, are they sitting up, are they laying on the floor? That's a huge documentation thing that we'll talk about later. But that is, you're listening, you're picking up like gurgling respirations. Are they full of fluid and they're gurgling, right? Snoring respirations. Snoring respirations is a sign of what? Right, partial airway obstruction. So that's a problem, right? Smells. This would give you an indication, especially vomit, right? Are the patient sick? You smell vomitous, urine. Are they, how clean are they? Are they urinating or, pooping all over themselves? Are they that sick? Is it a GI bleed? You'll notice that right away when you come into the house, right? Decay, like in a possible DOS, or what we would call signal 27, you walk into the house and you smell the patient. They've been dead for a while. So your senses play an important role as you go through there. Gas, is there a gas leak? Are there other things that when you walk in that you can pick up through just your smell? So when we look at the chief complaint is what the patient tells you. So I have abdominal pain. My little toe hurts. And then just like here on your chief complaint, when you go to document this, you would put the chief complaint in quotes. Remember, the chief complaint is abbreviated C over C. And then C/O is complaining of. So their chief complaint is that my little toe hurts. Complaining of tenderness or swelling or something else. The complaining of follows the chief complaint. That's the other signs and symptoms that you see or the patient's telling you is what they're complaining of. Some of them can be pretty vague, like this one. I'm not feeling good. What does that mean? I don't feel very good right now either, right? That doesn't tell you very much. So through your patient assessment skills, you, in your sample history that we'll talk about next few chapters, you'll pull that information out of them. Then you'll know that they're not feeling well. They ate that 2-day-old Subway sandwich for lunch, and it's starting to churn in their belly, and they don't feel good. They're about to throw up. Maybe that meat wasn't supposed to be green. It's not, what's that? Oh, I'm having an old moment. St. Patrick's Day anymore. The meat's not supposed to be green. So you have to sometimes you have to sort of drag the information out of them. You also have to drag the information out of them. Sometimes they say, no, I'm having a little chest pain. What do you mean by a little chest pain? And so you ask them, and you have to ask a lot of questions to figure out what's taking place with the patient. And when we talked about the AVPU scale before, correct? So you alert. Most everybody's alert. And I would come over here. Oh, you ruined my example. So her eyes were still closed. I'd have to come up and go, are you okay? If they're in EMS, you sort of kick them, but are you okay? And she responds with eye opening. That would be to verbal, right? But you guys have your eyes open, so you're alert. If they're alert to a verbal response, then it would be V. Painful would be like when you would do a sternal rub. So you come up, and all this takes place at the same time. You go, hey, are you okay? Their eyes don't open. Eyes are not open. So you give them a verbal response, or hey, are you okay? As soon as they don't respond to that, you give a sternal rub. They don't respond to that, then they're unresponsive, right?
If they respond to verbal, do you think it's a beautiful response? Or you just stop right
Yeah,
there?
you stop there. Unless they just didn't respond good to you, then be like, hey, are you okay? And they open their eyes and go, no, you're not. I want to do the sternal rub. Yeah, you would stop, and then you would go, I'm okay. Leave me alone. No, I want to do this again. Do that sternal rub again. So then you would document their mental status according to the AVPU scale. Very important here. This gives a baseline. All right, so now you're reassessing the patient, and all of a sudden the patient was alert, but now they're only alert to a verbal stimulus or a painful stimulus. So they're having a decrease in their mental status when you reassess the patient. Now you have to go back and figure out why that's taking place. This is why this is so important to get this as a baseline. Without the baseline mental status or the baseline vital signs, you don't have a place to go back to. You sort of lose your point of origin. So it's very important to get these. Then the ABCs, we've already went through. Airway, make sure that they have a patent airway or open airway. They're able to get air from the atmosphere into the lungs. Make sure they're breathing and make sure they have a pulse. Airway also deals with suctioning. They have foreign vomitus or like sputum in their airway. You're going to have to suction that out. That's part of airway. Airway is also giving oxygen. If they need oxygen, you take care of their airway by giving them oxygen. That all sort of fits in there. From, like I said, from nasal cannula to suctioning to non-rebreather, the bag valve mask. That all fits in that airway. OPA, NPA, all that fits into taking care of the patient's airway. So when you look at their breathing, are they breathing? They're in respiratory rest. It's an inadequate. later we'll put definitions behind this. What's adequate, what's inadequate. You know, is it a normal rate? Do they have good symmetrical rise and fall of the chest? Are they cyanotic? That would be a sign that they're not breathing very well, that they're not getting in enough oxygen, right? That their cells are not taking in enough oxygen for some reason. Hypoxia. Hypoxia can lead to altered mental status. What's hypoxia? What's hypoxia? 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 Huh? I just can't hear you.
I said low oxygen.
To what? With the cells. You're right.
Oh, yeah.
Hypoxia means low. Hypo meaning low. And this sort of last part of the word, you see that it has to do with oxygen. So hypoxia is a decrease in oxygen to the cells for some reason. You know, and there's several reasons for a patient to be hypoxic. Check the skin, check the pulse, the skin. Are they bleeding? Do you see blood? Actively bleeding, we need to make sure that we control that. Check the unconscious person, check the carotid pulse for at least 10 seconds. But make sure that you check a good pulse. And then that when you check a pulse in the primary assessment, you're looking to make sure it's present, and then if it's fast or slow. That's the only thing that you're looking for. So you reach down, you got a radial pulse, and you say, okay, it's there, but it doesn't appear to be fast or slow. It appears to be normal. You'll know what it means. Unusually fast or unusually slow. So maybe we'll have somebody run around the building or something, check their pulse. And someone do a vagal maneuver, then you get unusually slow and unusually fast, right? But as you practice on the vital signs and checking pulse, you get a sense of what is normal, okay, and what's abnormal. But here, when you're checking for circulation, it's just unusually fast or slow. The skin, is it warm, pink, and dry, or is it clammy? Does it feel cold, or is the patient normal, warm, pink, and dry? And you can do that. You can touch your skin and go, okay, that's warm. Pink, normal color, right? Dry. We'll go into a better explanation of this during patient assessment when we start looking at different paleness. Are they pale? Are they red? Are they flushed? Different things of that. Abnormal events a little bit later. If they're not, if they need immediate intervention, then that's where you would stop. You know, if they need CPR, you would stop there and start CPR, right? Or if they're bleeding, you walk up to them and they're bleeding out their carotid artery, they're squirting blood all over the place. You would stop right there and stop that bleeding, right? You wouldn't necessarily go through a whole big ordeal. If blood's coming out of your neck, right? I'm going to stop what I'm doing and cover that up. No problem. Before I go on to check your radial pulse. Correct? All right. Are they stable or unstable? Here you look at the vital signs. Are they stable? What leads me to believe that they're unstable? And then right through here, do I need ALS backup? As we enter into patient assessment more in the next few days, we'll talk about the need for ALS backup and the different conditions that you might need this. And then, are they completely unstable? Right? And you have to transport right away. So those are different things that we'll be breaking down over the next few classes. And the need for priority transport. I put this down here at the bottom. An ambulance is called a mobile intensive care unit. MICU is what MICU means mobile intensive care unit. It's mobile for a reason. People call an ambulance to go to the hospital. See, a lot of pre-hospital providers, they sit on scene a long time. And so they would define that length of time. Like with trauma, you have 10 minutes essentially to get on scene and get off of the scene. So they spend way too much time on scene. And the patient starts to go downhill and they're still on scene. Take them. Ambulance people are trained to do everything in the back of a moving vehicle. That's where we operate the best. Not sitting. You load the patient in there and you go to the hospital. So we're very mobile. All right. So again, through this patient assessments at medical trauma, altered mental status, child or adult, you always sort of have to sort these things out as you go through. Is this a medical call? Is this a trauma? Is it a medical call, but is there trauma involved due to maybe the guy had a heart attack and fell off his balcony, right? It had started medical, but it ended up trauma. Why does the patient have altered mental status? ABCs, priority of transport. These steps are very important to sort of get down as a systematic approach. When we start teaching you guys patient assessment, the patient assessment is a systematic approach. So the system is to start up here with your size up, general impression, mental status check, ABCs, determine the number of patients, determine the need for transport, right? So it lists these steps out because they put an emphasis on a systematic approach. Look at it. Okay. Any questions there? I mean, that's a lot of stuff just to say check your ABCs, right? Do your ABCs.